TAYYABA. Today we will discuss about the benign tumors of the corpus uterine. Can you hear me? आपको आवाज आ रही?
जी मैम आवाज आ रही है, क्लियर है आवाज आपकी.
Okay. Before discussing the benign tumors of the uterus, it is necessary to understand the term the heavy menstrual bleeding and the abnormal uterine bleeding. Heavy menstrual bleeding, excessive menstrual blood loss which interferes. Heavy menstrual bleeding is defined as the excessive menstrual blood loss which interferes with a woman's physical, emotional, social, and material quality of life and which can occur alone or in combination with other symptoms. Other symptoms means dysmenorrhea, dyspareunia, intermenstrual bleeding, postpartum bleeding. That is called heavy menstrual bleeding. Previously, heavy menstrual bleeding, we use the term anorexia instead of using the heavy menstrual bleeding, and it shows that the patient or the woman who have lost more than 80 ml comes in the category of the anorexia or the heavy menstrual bleeding. But now the definition has been changed. It's defined as excessive menstrual loss which interferes with a woman's physical, emotional, social, and material quality of life, and which can occur alone or in combination with other symptoms. There is another definition which is defined by the FIGO. The FIGO is the International Federation of Gynecologists and the Obstetricians. They define abnormal uterine bleeding as the bleeding from the uterine corpus that is abnormal in volume, regularity, or timing that has been present for the majority of the last 6 months. It's called abnormal uterine bleeding. Acutely or heavy menstrual bleeding. The incidence is quite common. It usually occurs in the 4 to 50% of women, though the incidence is from the Western world, but the true incidence we see in our patients like in tertiary care centers is usually more than 50%, around 50%. Most of the incidents, if we take the subjective self-assessment test, your patient's complaints, so it corresponds or is estimated to be about 20% to 25%. If we use the objective measurement by using some tools, the incidence is estimated to be about 9 to 13%. That is called the true incidence. But sometimes the patient complaints are excessive or aggravates the complaint of bleeding or the associated symptoms. There are many causes for the heavy menstrual bleeding because the heavy menstrual bleeding is from the uterus, not from the cervix. Because usually the bleeding from the cervix is intermenstrual bleeding or the postpartum bleeding. The vein pathology is usually not causes heavy menstrual bleeding until unless they have the hormone-secreting tumors like gonadal cell tumors, theta cell tumors, and other like endoblastoma. So usually the heavy menstrual bleeding which occurs in women is from the uterine side. So we usually classify this into the structural causes and the non-structural causes. The structural causes are the polyps, the adenomyosis, the leiomyoma. Leiomyoma has different categories. We will discuss it later, like submucosal. It depends upon the classification. It depends upon the size and the size. Like submucosal fibroids, intramural fibroids, and the subserosal fibroids. Also, there are the fibroids which are located in the cervix called the cervical fibroids. Sometimes the fibroids are located in the broad ligament. And sometimes the fibroid become parasitic. They gain the blood supply from some other organs. These are the structural causes for the heavy menstrual bleeding. Now we come on the non-structural causes. Non-structural causes are those which are not related to the uterus, but they are defined as systemic disorders like coagulopathy of any type, like Von-Willebrand disease, ovulatory dysfunctions like PCO, polycystic ovarian disease, thyroid dysfunction. Sometimes the bleeding is from the endometrial dysfunction, and sometimes it becomes iatrogenic. There is no cause for that type of bleeding, or sometimes it is categorized as not yet classified because sometimes when the bleeding is associated of using some contraception, some drugs, or by some arteriovenous malformations. The management of the heavy menstrual bleeding, when one comes to you with complaints of heavy menstrual bleeding, the management starts from the history. You have to take the history in detail about the bleeding, the duration of the bleeding, the intensity of the bleeding, the rhythm of the bleeding. It's all about the history of the menstrual cycle. You have to take the history of menstrual cycle in detail about intermenstrual bleeding, postpartum bleeding, use of any drug, any systemic disorder, any coagulopathy, and family history, any comorbids like diabetes or hypertension, previous history of PCOS, if patient has annularity cycles or thyroid dysfunction. So we have to take the history in detail. Previous surgical histories, like if patient has some sort of surgical interventions like diagnostic DNCs, like suction evacuation, like myomectomy, or previous history of any stereoscopic removal of the fibroid. So these you have to take the history in detail, and after history you have to do the examination in detail. The examination usually starts with general physical examination, vitals, but the important is in this category, the important in this is the abdominal and pelvic examination. The basic investigation usually done for the heavy menstrual bleeding is the CBC to assess the patient complaints by comparing the patient's status of anemia, like CBC. We see the hemoglobin of the patient. If the patient hemoglobin comes 10 and the patient complains of heavy menstrual bleeding, so you have to ask about the previous transfusion, parenteral use, or the iron use. You have to ask about all of them. And the basic investigation includes the ultrasound. If you have done the pelvic or the abdominal examination and you assess that patient has some sort of central mass located in the uterus, you will go for ultrasound. Additional tests like thyroid stimulating hormone, serum ferritin, and TIYABA, when it is needed or it's indicated. Further investigation for heavy menstrual bleeding may be the transvaginal ultrasound. If the patient has an abdominal mass or pelvic mass less than 12 weeks, so it's better to have a transvaginal ultrasound. If the mass is palpable transabdominal, you will go for the transabdominal ultrasound. Sometimes there is a coincident pathology beside having the uterus or beside having the fibroid or the polyp. We can go for the endometrial biopsy to exclude the other diseases like patient may have malignancy. Hysteroscopy. Hysteroscopy is sometimes used for a diagnostic purpose and for the therapeutic purpose. Because sometimes you can remove, you have a direct method of examination on hysteroscopy. You can remove the polyp or the small fibroid at the time of examination. The diagnostic DNC is a blind procedure. Sometimes you can miss the fibroid, small fibroid or seedling fibroids or the polyps on the diagnostic DNC. But these are further investigations which help in ruling out the exact pathology. Now come to the intermenstrual bleeding and postpartum bleeding. As we say, as I have discussed previously, that intermenstrual bleeding and postpartum bleeding usually occurs when patient has some sort of cervical pathology, like cervical growth, cervical malignancies. Careful examination of cervix is essential before doing the pervaginal examination or the abdominal examination. Pervaginal examination. The careful examination of the cervix is essential. By doing the perspective examination, you have to see the cervix. Along the cervix, you have to visualize the vagina. Because some hidden pathologies may involve the vulva. The vulvans here, sometimes coincidentally form along with the CNE. You have to take the pap smear to rule out, and also we have do the pap smear for the screening purpose. If you found something abnormal, you can use the colposcopy to rule out that pathology. There are a list of medical options available for HMB or the heavy menstrual bleeding. The first line treatment is the anti-fibrotic agent and NSAIDs. NSAIDs. Now, the second line of management is available. I have combined oral contraceptive pills, progesterones, levonorgestrel, intrauterine contraceptive device, danazol, and GnRH. Usually, the patient has temporary relief after getting anti-fibrotic agent and NSAIDs. The COCPs can be used with the progestogens, but there are some side effects associated with the combined oral contraceptive pills and progestogens. and they are not potent in control of bleeding as compared to the levonorgestrel intrauterine system or GnRH analog. They give the patient effect, but it's not potent. Levonorgestrel intrauterine system has local effect. It also gives contraception if patients desire or wish to have contraception along with it. That danazol. Nowadays, danazol is obsolete because of the side effect associated with the use of danazols like acne, hair hoarseness, voices, and all these problems. The GnRH analog. The GnRH is basically the expensive one. The injection costs around 11,000 to 12,000. The patient use on a monthly basis or quarterly, 3 monthly basis. It has some side effects which mimic to the postmenopausal symptoms, like the patient has hot flushes, vaginal dryness. Along with that, patient has cold problems like osteoporosis. So when we give the GnRH for the control of bleeding, we usually provide patient or give option to the patient to use that therapy in the form of low-dose estrogens or progesterones. Besides having list of medical options, we have some surgical options like endometrial ablation. We use microwave and thermal ablation to dissect the endometrium. Other is the myomectomy and the hysterectomy. Along with that, we have the UAE, uterine artery embolization. These are all the surgical management options which are available for control of HMB. Myomectomy and hysterectomy is the major surgical procedures. There is a chance of recurrence in case of myomectomy. Patient has gone, the patient opt for myomectomy. There is a chance the patient recurrence in case of fibroid. Hysterectomy is the last resort, and is the we come to the topic, the benign tumors of the uterus. The benign tumors of the uterus comprises of the endometrial polyp and the uterine fibroid, which is also called the myomyomas and the myomas. As we discussed earlier, the polyp is the outgrowth of the endometrium, which contains the glandular tissues and the blood vessels. Aside that, uterine fibroid is not the outgrowth of glandular tissues or the blood vessels. Uterine fibroid is basically the benign tumors originate from the smooth muscle cells. And these are just covered with a layer of endometrium. It is originated basically from the muscle layer of the uterus. Uterus has 3 layers: the endometrium, the myometrium, and the serosal layer. Usually the fibroid, and then first we will discuss about the endometrial polyp. Endometrial polyp is defined as a discrete outgrowth of the endometrium containing a variable amount of glandular tissue, stroma, and blood vessels. They have no smooth muscle cells in the endometrial polyp. Endometrial polyp may be pedunculated or sessile, single or multiple, but they are insensitive to cyclical hormone and are usually not shown at the time of menstruation because they are not responding on the cyclical hormones. Insensitive to cyclical hormones. The polyps are there below the age of 20 years. They usually occur after the age of 40 years and the postmenopausal woman. In the woman is symptomatic, the prevalence is around 6 and 32%. Sometimes the chance of malignant foci in the polyp, which is rare, but the incidence of cancer or the coincidence of cancer along with polyp in asymptomatic women. Asymptomatic women means the polyp is identified incidentally while doing ultrasound examination, so for some other purpose. But the incidence of cancer in asymptomatic polyp is 1.1 to 1.5%. And when the patient has symptoms, like patient has postmenopausal bleeding, the incidence is 1% to 4.5%. Usually the patients present with polyp, they have symptoms like the heavy menstrual bleeding. If it occurs, usually occurs after 40, but before 40, after 40 and before 50. I mean, before the menopause, the patient had heavy menstrual bleeding due to endometrial hyperplasia or the perimenopausal phase. So usually patient presents along with polyp is the case of heavy menstrual bleeding. If it occurs after 40, the patient's symptoms are usually postmenopausal bleeding. Postmenopausal bleeding when the patient has polyp. Also, when patient has heavy menstrual bleeding due to polyp, either it's a uterine polyp or it's a polyp which is arising from the cervix, the patient presents with intermenstrual bleeding. Sometimes these patients also present with postpartum bleeding is that polyp is hanging outside the uterine cavity or it's originating from the cervix. Right now we are discussing about the endometrial polyp, not the cervical polyp, but you have to get an idea if the patient has cervical polyp, the patient usual symptoms are the postmenopausal bleeding and the postpartum bleeding. And when the polyp is hanging from the uterine cavity outside, it also causes the symptoms like the postpartum bleeding. We have to differentiate both the polyps on the basis of first on the clinical examination. When we insert the speculum, we can see the polyp either it's originating from the cervix or it's coming out through the pus or from the upper body of the uterus or the corpus luteum. Along with that, the patient with polyps also complains of dysmenorrhea. This dysmenorrhea is of secondary type because there are two types of dysmenorrhea, the primary dysmenorrhea and the secondary dysmenorrhea. Primary dysmenorrhea lasts for 24 to 48 hours and it's after 48 hours or lasts throughout the menstrual phase or the bleeding days, that is called the secondary dysmenorrhea. The people with polyp usually present with these symptoms. Subfertility. Sometimes these polyps are associated with subfertility because the patient has multiple treatments or the patient have family history of polyp. The patient on incidental finding or just on the investigation we are doing at the time of subfertility investigation, we incidentally find these polyps on ultrasound, and sometimes it is associated with subfertility because having the polyp or some uterine mass, the patient has a history of miscarriages, the first trimester or the second trimester. The diagnosis depends again on the symptoms of the patient, on the clinical features of the patient. Usually, patient has all these symptoms, and the patient comes to you after taking the history. You will go for the examination. As we said previously, the examination include the general physical examination, the vitals do in any case, but the typical examination after inserting the speculum, you will find the polyp. And after that perispeculum examination, we will go for the vaginal examination. We will assess the uterine size. Usually, when the patient has polyps, the uterus is usually feel normal in size or bulky in size. So the diagnosis after the clinical feature in the examination depends on the transvaginal ultrasound. We will go for the transvaginal ultrasound because the transvaginal ultrasound resolution is better than the transabdominal ultrasound. We can make the spot diagnosis when we are doing the hysteroscopy because hysteroscopy works as a diagnostic purpose and also as a therapeutic purpose because hysteroscopy is an office procedure. When we are doing the hysteroscopy, at that time we can also do the therapeutic resection of that polyp, but the patient already given the consent for that. The hysteroscopy is the gold standard for the removal of the polyp, and the other methods are available for the diagnosis, like the tube installation sonography, in which we instill the normal saline in the uterine cavity because after installation of the normal saline or some fluid in the uterine cavity is delineated easily and we can see easily the polyp. But along with that, we can't do the hysteroscopy. Hysteroscopy also needs the installation of the fluid in the hysteroscopy. But it will be difficult to do the ultrasound and the resection at the same time. We can't do the resection only with the help of ultrasound. We need a stereoscope, a specialized instrument for the resection of that polyp. The dilatation in previously the method used is the dilatation in curative and the stereoscopy is not available. The dilatation in curative, where diagnostic DNC is a blind procedure. Sometimes we miss polyp or any growth. while doing the dilatation and curative. You can't see the uterine cavity, and there's a high chance that can miss the polyp on the procedure like diagnostic ANC or the dilatation and curative. Pipil is another device. It's like a telescope. You can see in the figure. It's just like a telescope is the inside and the outside tube, or the inner tube or the outer tube. These both tubes creates the negative pressure, and that negative pressure helps in taking out the endometrial lining. But it's not possible to take the polyp along with that telescope because there's not much pressure to extract or to reset the polyp on just taking out the pipil sample. This figure is showing the pipil because the pipil is helpful in finding out the excluding the other pathologies like endometrial hyperplasia, sometimes occur in patients with polyps. You can see the pipil is just helping out to take out the samples of the endometrial ratings by creating the negative pressure, and then collect all aspiration in sample jar containing a fixator, usually the formalin, inside it for histopathology. They will help in the diagnosis but not help in the removal of the polyp or in the identification of the exclusion of the polyp. The polyp is excluded only on the basis of the transvaginal ultrasound, can be excluded on the basis of the transvaginal ultrasound or the section of the polyp at the same time. It works as a diagnosis and the therapeutic option for the patient. The treatment is usually the excision and the direct vision, and which is possible with the help of hysteroscopy. So this is all about the polyp. Now comes on the uterine fibroid. Uterine fibroid, the most common tumors arising from the myometrium of the uterus. Most common means usually the patient presented in the OPD or the gynecological department with a complaint of heavy menstrual bleeding, and more than 50% of patients have the uterine fibroid. It's usually arises from the myometrium of the uterus, sometimes arises from the broad ligament of the uterus, as we discussed previously. It is composed primarily of smooth muscles but may contain fibrous tissue. The gross structure of the fibroid looks like the words, just like the, if you have seen the onion has a word appearance, just like that, the gross appearance of the fibroid mimic the onion. The vast majority of the fibroid is usually found in the body of the uterus, but is also occur in the cervix, the uterine ligaments, and also in the ovary. Sometimes it may be single, or sometimes it may be multiple, sometimes it may be small in size, just like the seedling fibroid, and sometimes you get a larger size of the fibroid, maybe 18 weeks. 18 weeks just to mimic the 18 weeks as around the size which mimic or which resembles the 18-week size or below the umbilicus. Sometimes the size is large and sometimes the size is small. The National Federation of the Gynecologists and Obstetricians have classified the fibroid according to the site. It is formed from the 0 and ends on the 8. Here you can see there are 9 types of fibroid, or the FIGO classified the uterine fibroid into 9 categories. The 0 means the fibroid is pedunculated and it's called intracavitary, means there is some mucosal fibroids which projects into the uterine cavity. We categorize it by the 0. The type 1. Type 1 is called the submucosal fibroid when it involves less than 50% of myometrium, the intramural tissue. It is called submucosal, but it involves more than 50% of intramural, because the uterus is 3 lines: the submucosa, the myometrium, and the serosal. When it becomes 100% mural, but involves whole of the muscle layer of the uterus, but in contact with the endometrium, because the inner side the myometrium is covered with the submucosal layer. Other is the intramural. Intramural, when it involves whole of the muscle layer. The 5 is categorized as the subserosal. Subserosal, when it's more than or 50% intramural but below the serosal. If it is subserosal, it involves less than 50% intramural and below the serosal. There are certain subserosal pedunculated fibroid which projects into the abdominal cavity. Other are the categorized number 8, like cervical or the parasitic. Parasitic uterine fibroids are those fibroids which get their blood supply from some other structures. Like if it is subserosal, it may get the blood supply from the intestine, from the omentum, from the ovaries. Now the FIGO is a new classification, and the FIGO classified the uterine fibroid into 9 categories according to their site. This is the figure or the diagram which is showing the site of the fibroid. You can see this is the pedunculated fibroid, which is a stalk, and these are the sessile fibroids. They have no stalks. But a subserosal, both are subserosal, but it's pedunculated and it is subserosal. Likewise, these are the submucosal fibroids covered by the submucosal layer or below the submucosa. It involves, because it arises from the myometrium, so it has taken the 50% or more than the 50% of the intramural side. This is the whole intramural fibroid which is in the muscle layer of the uterus. Sometimes the fibroid arising from the cervix is called the cervical fibroid. The incidence of the fibroid usually increases with age, and it usually occurs in a woman who have a reproductive age. It's not commonly occur in patients at extremes of ages like the teenage or the perimenopausal woman or after the age of 40 years. It usually occurs in the 20s and 30s groups of patients. It usually occurs in 20 to 40% of women during reproductive life, and around 50% of women belongs to the 20 and 30 decades of life. The incidence of malignancy in uterine fibroid, there is a chance, but it's rare, and it's called when there's a chance of malignancy or the uterus have a malignancy or the malignant potential. It's called leiomyosarcoma. The incidence is 0.64% per 100,000 women per year, and is uncommon below the age of 40 years. Usually, the incidence of malignancy is more in patients who have teenage or about the age of 40 years. Symptoms. 50% of the uterine fibroids are symptomatic and 50% are asymptomatic. And the symptoms are usually, and the biggest symptoms is the heavy menstrual bleeding. Heavy menstrual bleeding, as we discussed it earlier, sometimes along with heavy menstrual bleeding, patient has other symptoms like dysmenorrhea, because if the patient has a uterine mass, the uterus will try to expel that mass, and that causes dysmenorrhea. This is usually a secondary type of dysmenorrhea. If the size of the uterus is large, the patient has some facial symptoms depending upon the size of the fibroids. Like patients sometimes have ball symptoms, like patient has complaint of constipation. Sometimes patient has urinary symptoms like difficulty in passing of urine, incomplete emptying of the bladder, the increased frequency of menstruation, and difficulty in passing urine. These are called the facial symptoms. Sometimes with huge fibroids, patient may have GI symptoms, upper GI symptoms like patient has fullness, heaviness, gastric disturbance like ulcers or increased acidity. Along with that dysmenorrhea, patient has dragging sensation of feeling patient in the pelvis if patient has huge or large fibroids. There are some reproductive dysfunctions which are also associated with the uterine fibroids. The patient has fibroids, they may fail to conceive, or sometimes these fibroids are incidental while doing the investigation. The patient comes to lose of fertility. Sometimes these fibroids are associated with miscarriages. Sometimes, usually, they are associated with the second trimester miscarriages. Sometimes, usually with the second trimester, sometimes with the first trimester miscarriages. They have some problems. If patient conceives with fibroid, the patient has some problems in their pregnancy, like miscarriages, abnormal lie, difficult delivery, increased chance of cesarean sections, operated deliveries, and increased chance of PPH for the primary postpartum hemorrhage. Diagnosis: usually the patient's clinical features and examination reveals the diagnosis, and it's easy to read the diagnosis, but sometimes when the patient has symptoms and you can't find, and the patient is obese, the patient is obese and you can't properly go for the vaginal examination, so you can take the help by doing the ultrasound examination. But usually if the patient has a larger fibroids or the size of the uterus is more than 12 weeks, you can easily make the diagnosis because the firmness of the mass help in making the diagnosis. Usually the fibroid are firm in nature or centrally located, easy to make the diagnosis on just clinical examination. But you can also take the help with the ultrasound. Ultrasound is definitely a good opportunity to make the diagnosis, but sometimes if you can't make the diagnosis on just the clinical examination on the ultrasound, you can take the help by sending the patient for MRI or the magnetic resonance imaging. The treatment of the fibroid usually depends upon the site and the size of the fibroid. It's not necessary that each and every fibroid, the patient comes to you, either she is asymptomatic, you will go for the treatment because the asymptomatic patient will not need any treatment until unless patient has some other comorbids, like patient has symptoms of dysmenorrhea, pelvic pain, pressure symptoms. Sometimes patient has fibroid, it may be subserosal. It doesn't cause any heavy menstrual bleeding, and it's just a finding or an incidental finding. The management usually depends upon the size and type of fibroid. Sometimes it also depends upon the patient age or the patient age. At what age patient is presenting to you. If patient is presenting to you in reproductive age and the fibroid is bigger in size and it causes symptoms, patient has heavy menstrual bleeding, patient is subfertile, so this patient needs treatment. But if patient comes to you with subfertility or for the investigation of subfertility, and you incidentally find a seedling fibroid, the patient has no symptoms, so there is no need to resect or to go for the treatment of that fibroid. But the patient can conceive with the presence of fibroid. Until unless if this fibroid is located at the cornal end of the uterus, it's blocking the tube, or it is located in the cervix, so it is causing hindrance in the ascending of the sperm, but it's unlikely that it causes problem for the ascent of sperm. It is unusual. And also the patient desire to preserve fertility. Sometimes patient has completed a family, but she is reluctant to remove the uterus. So there are certain other options which we can use. So the management depends upon not only on the size and the type of fibroid. It also depends on the patient's age. Because if the patient is in her reproductive age, 20 and 30, and patient has symptoms, patient can be treated. But if patient is near the menopause, then patient has no symptoms and it's an incidental finding on ultrasound, the patient has fibroid. So there is no need to give any treatment. You have to counsel your patient that if the patient has menopause, the fibroids will shrink in size and there is no need of any treatment. There will be no need for treatment. And also upon patients, if the patient comes to you is 20-30, patient has symptoms. Sometimes patient in 20-30 comes with ultrasound is showing that they have fibroids. So we have to counsel the patient because unnecessary treatment create or increase the morbidity of the patients. Because if patient go for myomectomy, hysterectomy, or uterine artery embolization, all these procedures have certain complications. It starts from the anesthesia complication and also it has some procedure complications. Management. As we discussed, there are certain medical management options and certain are the surgical options. The medical management starts, as we discussed earlier, with the antifibrinolytic like tranexamic acid or NSAIDs like Constant Post or any NSAIDs, naproxen or other. But these are all antifibrinolytic agent, tranexamic acid or the NSAIDs usually give the temporary relief. The patient use all these treatment options, or all the antifibrinolytic of patient, the symptoms will subside. It again comes. The second line of options includes the COCPs, progestogens, and GnRH analogs, and the danazol. The COCPs or the combined oral contraceptive pills usually gives patient the relief. Hence, the relief is more than the antifibrinolytic agent, but it's not as much effective in giving the relief because the COCPs has a negative feedback on the pituitary or the hypothalamus. The COCPs, because it contains insulin and progesterone, the negative feedback, and then negative metabolic degrees on FSH and then suppress the cycle, and there will be no bleeding or no shedding of endometrium. But this all are not very much effective in reducing or shrinking of the size of the fibroid. The other option is the danazol. Danazol is also a hormone that comes into the second line management along with progestogens, but the progestogens has some undesirable effect if patient took the progestogens. Like if patients take the first generation or second generation, the patient has some sort of progestin side effect and like acne, greasy skin, all these symptoms. That is also not effective in regressing the size or in reducing the bleeding. The menstrual cycles become short, but it doesn't have any effect on the size of the fibroid. Now, there is another hormonal treatment which is called the GnRH analogs. GnRH are expensive as compared to COCPs, progestogens, and danazol. Danazol are nowadays obsolete. The GnRH agonists are expensive, and they are given on a monthly basis or 2 monthly basis. They usually will give in the injection form, prepaid syringes as shown in the figure, or in the form of nasal spray. Usually in Pakistan, it's available in the injection form. The drawback of the GnRH analog is that when the patient is on GnRH analog, symptoms will be subsides. But as patient is stopped taking the treatment, the fibroid is again being grown. And the symptoms or the side effects associated after the use of GnRH are undesirable. But sometimes patient has postmenopausal symptoms because GnRH analog, as this figure shows, has a negative feedback. So there will be a suppression of the LH and FSH. So the fibroid will shrink in size because the fibroid is have the receptors which responds on estrogen and progesterone. So when there is a decreased formation of estrogen and progesterone, the size will be shrink. But the size will be shrink until the patient has these injections or the nasal sprays. The patient has mainly causes by hot flushes, the immediate effects like vaginal dryness, and the delayed effects like bone loss. We usually give patients 3 injections on a monthly basis. You can give your patient these injections for 6 months or 9 months. Next month. The symptoms the patient faces, the postmenopausal symptoms like hot flushes and vaginal dryness and bone loss can be stopped by giving patient the add-back therapy. Add-back therapy in the form of estrogen and progesterone. You can prescribe your patients the low-dose estrogen and progesterone. So sometimes the symptoms can be subsides. We also use these GnRH analogs in patients who have some comorbids, who are not fit for surgery, who refuse for surgical intervention. So this option can be used in these patients. It is also used, these GnRH analog can also be used preoperatively for the shrinkage of the size of the fibroid or for the correction of anemia. Because if the patient has symptoms like heavy menstrual bleeding, the patient will have anemia. When the patient has anemia, we have to transfuse the blood. Sometimes patient refuse for transfusion of blood, so you can give your patient preoperatively GnRH. It's not only helping the correction of anemia by stopping the bleeding, but it also reduces the size of the fibroid and it help in the surgical intervention. You can give your patient the options of laproscopy after the size reduction of fibroid, because the laproscopy has some advantages over the laparotomy or the open procedures. So GnRH is not only can be given for the shrinkage of the fibroid, the patient has some comorbid or patient refuses for surgical intervention. You can use this GnRH on a rod, also can be used preoperatively for the reduction of the shrinkage and size of the fibroid and also for the correction of anemia. They are also selected for a strong receptor modulator ANBREEN, which can reduce the heavy menstrual bleeding or the symptoms associated with the uterine fibroid or help in the reduction sometimes in the size of the fibroid, but it's not available in Pakistan. It is called mifepristone. It is effective in reducing pain, bleeding, fibroid size, and also improves the quality of life the women who have having these fibroids. But the side effects are the headaches and the breast tenderness, which are sometimes undesirable for the patients. The progesterone agonist action lead to unopposed estrogen stimulation of the endometrium. And this unopposed estrogen stimulation of the endometrium sometimes causing thickening of the endometrium. Another option, which is called the levonorgestrel intrauterine system. Levonorgestrel intrauterine system is an IUCD. It gives the local effect. It contains the levonorgestrel and progestogens, which belongs to the third generation. It has less effective progesterone. It also give effect locally. The patient can be the systemic side effects can be avoided in these patients by using levonorgestrel intrauterine contraceptive device. It can also be used as a contraceptive device if the patient has fibroid and patient also wants to use contraception. Levonorgestrel can be used to reduce the bleeding, and also it can help in the reduction of the size of the fibroid. Where patient has some comorbid, patient is not fit for surgery, patient wants to use contraception, patient refuse for surgery, and patient has no effect after taking the medical treatment, these patients can be offered this intrauterine system. But the levonorgestrel intrauterine system can be used in patients who have the fibroid, which are usually less than 3 centimeter in diameter, because if the size of the fibroid is bigger than 3 centimeter, some books says that it can be used, some literature says that the size of the fibroid can be used in the size if the size of the fibroid is up to the 5 centimeter, because the bigger size distort the uterine cavity and there's a high chance that if you insert the patient these IUCDs, it can be expelled. These levonorgestrel not only helps in the reduction of the menstrual loss and the rate of the, it can also give the patient the amenorrhea. And the rate of amenorrhea varies between 5 and 50% at 12 months of usage. So it's very effective in reducing the HMB and in resolving the other symptoms of the heavy menstrual bleeding. But it has some side effects. The effects are the increased risk of prolonged breakthrough bleeding because it is progesterone and patient using progesterone. There's a high chance the patient has prolonged breakthrough bleeding. And the other side effects that the patient experience is the expulsion. It can be expelled just like other IUCDs if it is not inserted by a skillful operator or the doctor. This diagram is showing the uterine cavity with an inserted IUCD, or you can say the levonorgestrel intrauterine contraceptive device. The surgical options. Patient has surgical options beside these medical options. The surgical option includes the hysteroscopic surgery, which is an office procedure. You can go for hysteroscopy for the therapeutic purpose, for the diagnostic purpose, and the therapeutic purpose. At the same time, without the need of general anesthesia. It can be done in the paracervical block or in the local anesthesia. At the time of examination, you can see the polyp or the fibroid and remove at the same times. But the drawback is that the procedure of the stereoscopic surgeries is usually restricted to type 0 and type 1. The type 0 and the submucosal fibroid is projected in the uterine cavity, and the type 1 are those which are included less than 50% of the myometrium and covered with a layer of submucosa, and it is also projected in the uterine cavity, and the size is usually around 3 to 5 centimeter in diameter, because the bigger from that size can't be used on the hysteroscopic surgeries. Type 2 fibroid, type 2 which involves more than the 50% of the muscle weight. The type 2 fibroid can also be managed, but after pre-treatment, GnRH analog of the user blood size will be shrink and it can be removed easily through the hysteroscopic resection. This procedure is not devoid of the certain complications. It has certain complications like the stereoscopic procedure usually done along with the fluid installation. After the installation of the normal slime, we use the stereoscope camera and the instrument to see and to remove or to reset excise that polyp or the fibroid. So there's a high chance the patient may have food overload, uterine perforation, and there's a chance of hemorrhage and infection. Other surgical option is the myomectomy. Myomectomy can be done laproscopically and by doing the laparotomy. But as compared to hysteroscopy, you need general anesthesia for both of the procedures. If myomectomy is done by laparoscopy or the laparotomy. Laparoscopy has some advantages over the laparotomy because it's a short procedure as compared to laparotomy, early recovery of the patient, less blood loss, and less hospitalization. Besides that, overall, after doing myomectomy, there's a high chance the patient has a recurrence of fibroid after myomectomy. The uterine artery embolization and the GnRH agonist can be used preoperatively to reduce blood loss. What is uterine artery embolization? Uterine artery embolization is a procedure in which we insert the polyvinyl chloride particles through the femoral artery, and it will embolize it and then make a thrombus at the uterine artery, and then it helps in the decrease the blood supply or stop the blood supply of that fibroid and causes shrinkage of that fibroid. Uterine artery embolization with the help of the interventional radiologist or the use of the GnRH analog can be used preoperatively before doing the myomectomy to reduce the size of the fibroid, and it also helps in the reduction of the blood loss during the procedure. The subserosal and intramural fibroids can be removed through laparoscopically because both of these fibroids projects in the abdominal cavity, so these fibroids can be removed laparoscopically very easily. But if the fibroid is projecting in the uterine cavity, like the submucosal fibroids or the intramural fibroids 0, 1, or 2, we have to go inside the uterine cavity and have to open the uterine cavity, which is possible by doing laparotomy. But there are certain restricted cases with no more than 3 fibroids and diameter smaller than 8 centimeter. It's all about laparoscopy. In laparoscopy, we remove the fibroids which are not more than 3 centimeter or not smaller than 8 centimeter. Because the larger fibroids, when we remove larger fibroids on laparoscopy, we usually do morcellation. Morcellation is a procedure in which we remove by doing morcellation, like we remove in pieces the bigger fibroids, and after that we remove their fibroids after opening the pouch of Douglas vaginally, that pieces, or by opening the abdomen. So larger fibroids, laparoscopy is not suitable for larger fibroids. The uterine artery embolization. Uterine artery embolization is an procedure, and it is getting much famous nowadays because it is for the treatment of the symptomatic fibroid, not for the asymptomatic fibroid, because this procedure is associated with certain complications. Usually the uterine artery embolization is performed under local anesthesia, and the radiological screening of the selective catheterization of the uterine artery. The single uterine arteries or the both of the uterine arteries are located and we insert the catheter from there. And after inserting, this is the diagram which is showing that we have inserted the catheter through the femoral artery, and then it is passed through the uterine artery, and from there, from the femoral artery port, we insert the polyvinyl particles to embolize that area. This procedure is also associated with certain complications, that is the puncture site bruising, the pain, the mild febrile reactions. Sometimes the patient may suffer from sepsis, vaginal discharge, and the ovarian failure. The fibroid shrinkage is usually gradual after the uterine artery embolization and reaching 60% at 6 months. But patient gain relief after that procedure and can discharge at the same time after 2 or 4 hours after that procedures. Usually patient have pain to keep the patient on painkillers. There is no need to keep the patient longer in a hospital. As we discussed, if a fibroid infection, we can remove surgically by opening the abdomen or by going through the pouch of Douglas or opening the posterior vaginal wall. Hysterectomy. Hysterectomy is the last option and it provides the permanent cure for fibroid, but it also depends on the patient's age. This option is also depends. This option is also depends on the patient's age. Young patients usually avoid hysterectomy due to desire of children's or heredity, and usually the patient after 40 years of age or the 45 years of age opt for this option. So it's a permanent cure of the fibroid. So it's all about fibroid and the polyp. If you have any question, you can send to the chat box. Okay. You have to select the patient. The patient should be symptomatic. First, we will discuss about the uterine artery embolization and give your answer. The uterine artery embolization is a procedure in which we involve the interventional radiologist. That person will do that catheterization, will insert the polyvinyl particle through the femoral artery. We use the femoral artery for this procedure, and after with the guiding, we insert that catheter into the uterine artery on the opposite side or on the same side, and we insert the polyvinyl particle through the femoral artery through this catheter. And this will form the emboli at the site of the fibroid or at the uterine artery. When the uterine artery is blocked, the blood supply will be stopped on that area, and then the fibroid will be shrink in few months. Can you please elaborate on the ADVEC therapy for GnRH agonist? ADVEC therapy is basically of the estrogen and progesterone. When we give the patient the GnRH agonist, it will suppress, it will give the negative feedback first, it will give the negative feedback, and there will be a FSH and LH will have a degree secretion of FSH and LH, and will have effect on the ovaries. The ovaries will stop measuring follicles, and the cycles will be stopped. When the cycle will be stopped, there will be no estrogen and progesterone. When there will be no estrogen and progesterone, the patient will face the postmenopausal symptoms. So when we give the patient the cyclical estrogen and progesterone, and then when the patient will take estrogen and progesterone, the symptoms the patient suffers like hot flushes and vaginal dryness will be subside. Then every treatment of fibroid side effect and the patient is not prepared for hysterectomy, then what we should describe. No procedure is 100% ideal. All procedures and medical options or the surgical options are associated with side effects, but you have to tailor according to the patient needs. We give the patient GnRH through an injection, subcutaneous injection. The pre-filled syringe is okay. It's not in the pulsatile. You have to give it once in a month and you have to repeat it for another 2 months. It's not pulsatile, it's a depot. You have given and there will be a release from that side. Yes, fibroids usually increases gradually in size. What is the difference for you? Class 3, 100% neural and 4 intramural. 100% neural, 4 intramural. Just a minute. Class 3 is 100% neural. It means it originates from the muscle layer of the uterus. 100% neural because if it is originating from the muscle, usually the fibroid is originating from the muscle layer or the myometrium of the uterine body. When it projects towards the uterine cavity, these are called the submucosal fibroid. When it projects in the abdominal cavity, it's called the serosal fibroids. Yes, both are classified as intramural. It is 100% intramural because it is in the myometrial layer of the uterine body. Any other question? If class 3 and 4 are both, what is the difference? Come on the slide. %, intramural, but in contact with the endometrium because it's projecting into the endometrial cavity. It is covered with the endometrial layer. It increases the surface area. The patient has high chance of heavy menstrual bleeding. The 4 is the intramural. Intramural means it is not covered with a layer of endometrium. It is inside or it is in the myometrial layer of the uterus. It is covered with endometrium. It is not covered endometrium. It means it's only in the myometrial layer of the uterus or the body of the uterus, and it's projecting into the endometrium. It is covered with a layer of endometrium. Before fibroids, what we learned. It's all about the heavy menstrual bleeding, about the signs and symptoms of the clinical features of the heavy menstrual bleeding. First, we discuss about the heavy menstrual bleeding, and then we discuss about the fibroid. Before fibroid, the polyp. Any other question? Now you have to go through your books. You have missed that. You have to be at the time of yes, the treatment of polyp is surgery. Now, why expulsion occurring? Even or install uterine contraceptive device. Because any IUCD, we have inserted any device or anything in the uterine cavity. The uterine cavity has an inborn capability to expel that foreign body. That's why there is a chance that this IUCD can also be expelled just like any other IUCD or foreign body. It's a foreign body and uterus will try to expel it. If you insert it properly, it will not be expelled. It will not cause perforation. Any other question? If patient is a young female with subfertility secondary to large fibroid, no, it's not necessary to treat fibroid and then subfertility. Subfertility can be treated in the presence of fibroid. It depends upon the site and the size of the fibroid. Usually the size doesn't matter for the treatment of subfertility, but the site is important. If it is obstructing the cornwall end, or it's obstructing or it's located in the cervix, so there should be a treatment. Otherwise, no need to treat fibroid before treating the subfertility. Patient can conceive with larger fibroids or the small fibroids. Other means the cervical fibroid or the parasitic fibroid. Usually the cervical fibroids are not responding as the fibroid located in the body of the uterus. And the parasitic fibroids are those fibroids which gain their blood supply from some other organ or the surrounding structures like intestine, omentum, ovaries, or any other structure. Patient have also back pain or any pain in spine by having fibroid. Usually patient have fibroid larger in size. It may cause pain because there are certain neurotransmitter interleukin or are secreting in the blood that causes pain. And also the fibroid. If the fibroid grow in size, that causes that blood supply, the blood supply of the periphery will be reduced. There will be a central blood supply in the fibroid. So there will be ischemic necrosis in the periphery of the fibroid that also causes pain. It is recommended to remove asymptomatic. There is no need to remove asymptomatic fibroid. Not causing any symptoms, because we remove the fibroid, the patient has to go through certain procedures, and all the procedure has certain type of complications. So why we should remove the asymptomatic fibroid in patients? There is no need to remove asymptomatic fibroid. Any other question? Transaminatic acid, NSAIDs. For temporary HMB, we can give OCPs, progestogens, danazol. Danazol is obsolete, but it can't be given. But other like GnRH. It's patient. If patient decide to have, if patient desire or the patient opt, their line of treatment, like starting from the transaminatic acid, NSAIDs, COCPs, GnRH, all are available for temporary leave or to stop the bleeding. Altogether, what do you think it should be given altogether? Starting from the first line of management, like transaminatic acid and NSAIDs, and then we can switch if patient is not responding on the antifibrinolytic or transaminatic acid. or the NSAID. They can switch the patient to some like OCPs, progestogens, Primolet. How is it possible to take all together? Sometimes you give patient the antifibrillatory agent like tranexamic acid, NSAIDs, and Primolet together. But if patient wants pregnancy, you can treat the patient. If asymptomatic, you can give the treatment for subfertility. If patient wants pregnancy, you can give the patient OCPs or the progesterone or sometimes the GnRH analog. And the symptoms subside, you can start the treatment because usually after the GnRH, the effect of the GnRH lasts only when there is a injection. It lasts only for a month from the last injection. So you can start treating your patient when the size of the fibroid is changed and the symptoms subsides. Any other question? No question? Which treatment is the best? No treatment is best. The best is patient opt and the patient decides and on which patient responds. That treatment is best. Only cure the patient get by having hysterectomy. Thank you.
जी मैडम एंड करें मैडम.
Okay, thank you.
Okay मैडम, अल्लाह हाफिज, टेक केयर.
Allah Hafiz.